Hello, my name is Dr. Jennifer Chung. I'm a cardiac surgeon at Toronto General Hospital. I'd like to thank the organizers of this academic half day for inviting me to talk to you. It's a pleasure. The title of my talk is Lifetime Management of Aortic Stenosis. So I'd like to start with a case. So 7 years ago, when he was 28 years old, a healthy male patient presented with severe bicuspid aortic valve stenosis and root aneurysm. After extensive counseling by the surgeon, the patient expressed that he really did not want warfarin and accepted the risks of having a bioprosthetic valve. Thus, a bioprosthetic valve, Bentall, was successfully performed. He's now 35 years old, still healthy, and referred to me with severe bioprosthetic stenosis and regurgitation. So, what should we do? What should we have done? And to understand that, we should know our valve replacement options. This can be categorized between TAVI and SAVR. And within SAVR, we have many options, including mechanical aortic valve replacement, bioprosthetic valve replacement, and the Ross procedure. The 2020 AHA valve guidelines divide up valve choices into age categories. So those under 50, those between 50 and 65, and those over 65 years old. And this is a very logical way of thinking about valve choice options, with the caveat that we do, of course, care a lot more about life expectancy than age. We understand that a 40-year-old with many comorbidities and end-stage renal disease, substance use disorder is not the same as any other 40-year-old and is physiologically much older. So with that caveat, let's break patients up into these age categories and think through this a little bit more. So this data I got from the Statistics Canada website. You can find actuarial tables there that describe a given person's life expectancy. So starting with a patient who is 75 years old or older, this patient is expected to live up to 13 more years. And in this age category, really our primary valve choice option is TAVI. The dramatically quicker recovery time is of paramount importance to patients in this age group, and it really does trump a lot of the other considerations. That being said, there are many other considerations, and I'm sure we can go into that later in more detail if desired. But for the most part, if you're over 75, we're going to primarily think about TAVI before considering surgical options. On the other hand, if you're between 65 and 75, a lot more nuance needs to be discussed when it comes to TAVI versus a bioprosthetic aortic valve. Now, this patient is expected to live up to 20 years. For lots of these patients, this valve will be their last valve, but for a good proportion, we would still expect a potential reintervention. Okay, so that is something to remember. So when considering TAVI versus SAVR, we are all familiar with the Partner 3 trial of TAVI versus SAVR in low-risk patients. So here we picture a 70-year-old with hypertension, dyslipidemia, and not much else. For this patient population, we now have 5-year data, and all the primary endpoints, death, stroke, etc., are all the same between the two age groups. There are, of course, many other considerations, though, before we say, well, these two things are completely equivalent, and so you really should have the less invasive option. So we have to think about whether or not the patient before us would have been enrolled in Partner 3 in the first place. Do they have a bicuspid aortic valve? Is there aortopathy involved? What about complex multivessel coronary disease, better suited for surgical AVR? For a coronary artery bypass grafting? or other severe concomitant valve disease for which there are other surgical indications. The second category of considerations include durability issues. So there's no evidence really that TAVI is any less durable than surgical valves, and perhaps some evidence to the contrary, in fact. But like I said earlier, for a proportion of patients in this age category, we may need to consider another intervention on this valve. And so we have to think about whether valve-in-valve would be possible. And also, if it's not, there is now ample evidence that explantation of a TAVI device carries more mortality and morbidity than you might expect, and certainly more than in a primary AVR. There are also conduction disease and pacemaker considerations, as well as paravalvular leak considerations. So pulling from the Partner 3 data, it turns out that with a lot of modifications to techniques, pacemaker rates are better, and this 13% for TAVI versus 10% for SAVR, which was not significant in this particular trial. Previously, the pacemaker rates were always higher. The mild plus PVL rate is still an issue for TAVI. This may be less important for an 80-year-old, but having mild plus paravalvular leak would be an important consideration in someone who's 65. Coronary reaccess is also more challenging in a patient who's had TAVI before. And when you are entering your 60s and 70s, for sure this is the age where people do develop coronary artery disease. Now moving on to the 50 to 60-year-old. Now this patient is expected to live up to 34 years. And so now we're really not talking about TAVI anymore. We can focus on surgical AVR options. And here we have primarily two, bioprosthetic valves versus mechanical valves. And here it's all about valve durability. So comparing bioprosthetic valves and mechanical valves, in this particular figure, bioprosthetic valves are in purple. And you can see that by 15 years, a quarter of patients will need reoperation on this valve. This is compared to less than 10% for a mechanical valve. We do have to remember that there's this concept of a competing risk of death. So this is well illustrated with this Cleveland Clinic study. In panel A, you can see this rising slope of people who die before their explant. And in terms of raw percentage, we're talking about 80% of people dying by 20 years. And so, of course, they're not getting their valve explanted, or they're not experiencing structural valve degeneration, if you will. This is related to the phenomenon of younger patients having a higher rate of explanting their valves, because, of course, they're living longer and then experiencing the need to explant their valves. But it's not just that they're living longer. There is a higher rate of structural valve degeneration in younger patients, as you can see from the final panel on the lower right, where those under 60 years old are experiencing structural valve degeneration in 50% of patients by 20 years. And there are other morbidities to consider besides just reintervention. And so for patients under 50 years old, this study shows that mechanical valves, which are illustrated in the red, have higher rates of stroke and higher rates of bleeding. And of course, the inconvenience is associated with warfarin as well. And so a lot of patients understand that the reintervention rate is higher, but there are still choosing bioprosthetic valves over mechanical valves for these issues. And so the increasing use of bioprosthetic valves in the young is directly related to the increasing use of valve and valve TAVI. And you can see that in red, how fast this volume of valve and valve TAVI is growing in the United States. And certainly patients are being counseled that they can have their bioprosthetic valve now, and then for their second valve, they can have valve and valve TAVI. So this strategy is viable for sure, but there are limitations. Number one, as you can see from the figure, the valve is very much constrained by the struts of the stent frame of the surgical valve that was placed. And so there are higher gradients associated with valve and valve TAVI, and patient prosthesis mismatch is a considerable issue. There are also issues with coronary obstruction with a neoskirt when we talk about valve and valve. And so the takeaway here is that you have to consider these things at the index operation. So if you are going to implant a bioprosthetic valve in a 50-year-old telling this patient that they can have valve and valve later, are you doing root enlargement to make sure you can get in a proper size valve so that valve and valve is feasible later on? And are you also taking care of where the coronaries are and making sure there would be enough distance should a valve and valve be required later on? So now moving into the youngest category of patients, this 28-year-old cardiac surgery resident. So she's expected to live another 54 years. So here we have three options on the table: bioprosthetic valves, mechanical valves, and the Ross procedure. So when we talk about bioprosthetic valves in this age category, we're now talking about potentially three valves for this young person in their lifetime. And so it's not a particularly appetizing choice, And so it would be considered in patients, for instance, who are young but have limited life expectancy, who are young but not reliable with warfarin, or a young woman who wants to be pregnant. Then they may accept a bioprosthetic valve now, and should it degenerate and they're finished family planning, then they can have a mechanical valve with their redo. So other than that, really, we are talking about mechanical valve versus the Ross procedure in this age category. So what is the Ross procedure? That's when we take the pulmonary autograft and move it into the aortic position, and you put a pulmonary homograft and put it in the pulmonary position. So it's a great procedure because it does have superior hemodynamics. It doesn't have a stent associated with it, of course, and so the gradients are very low. There's a natural living valve, and the dynamics of it are different than with the strutted valves. It's associated with better quality of life. There's no warfarin, of course. Lower rates of valve-related complications like stroke and bleeding, and there's also improved survival. So what do I mean by that? There have been multiple groups and multiple studies now that show the survival after the Ross procedure is equivalent to the age and sex matched control population. And this has never been shown with prosthetic valve replacements, and the contrary is true, where for all studies looking at long-term survival after prosthetic valve replacements have shown this survival cost with getting your valve changed. So the Ross procedure is very unique in that way. And you can see from the reintervention graph on the right as well that there's the reintervention rate over time is definitely there. It's definitely present, but it's probably on the order of about 1% per year. And so we looked at this data in Toronto as well. And so the Ross versus mechanical valves, you can see that freedom from major bleeding or stroke is much better for the Ross procedure versus the mechanical valve. And then freedom from valve-related reintervention in this particular study is about equivalent. So then let's return to that case I started with at the beginning of the talk, this 35-year-old who presents now with a degenerated bioprosthetic Bentall. So some thoughts here. His age category would be in that final category there. I think that there are many things to think about, but a redo Bentall is not the same as a redo AVR. So that's one consideration. And so you are committing this patient when he was 28 years old to definitely having a redo procedure without question. And so obviously a lot of patient counseling needed to have been done and was done, but probably a bioprosthetic Bentall would not have been what I would have necessarily pursued. Anyway, the point is I proceeded with the Ross procedure for this patient. This time around, hopefully resets him and he can have a nice durable valve solution for him, and also avoids warfarin, which he really still did not want to take. So takeaways: life expectancy dictates a valve choice in severe aortic stenosis. And a couple of points: while bioprosthetic or mechanical valves are reasonable for 50 to 60-year-olds, we must consider the limitations of valve and valve in that index operation to set them up for valve and valve in the future. For those even younger, the Ross procedure is a good alternative to mechanical valves. I do want to stress that mechanical valve replacement is still an outstanding procedure. And we should personalize the choice, and I'd like to emphasize shared decision-making with patients. Patients are, by and large, very, very capable of understanding actually this entire presentation that I just gave. You can walk them through these nuances. They do want to hear about it. And the consultations take obviously much longer now, especially in the TAVI era, than they used to. But I think everyone walks away feeling more satisfied after the discussion. And that's it. Thank you for listening.